My name is Preston Barlow. I'm a flight paramedic with Apollo Med Flight. I'm also a certified critical care flight paramedic. I currently have my bachelor's in science. And as of right now, I've got 3 interviews lined up for physician assistant school. So I'm pretty excited of covering the topic today, which is trauma in general. Except for that is so broad, I've kind of focused in on thoracic trauma and the importance of that, because our cardiopulmonary system is what helps us live. So we'll get started on that here. On March 30th, 1981, a newly elected President, Ronald Reagan, was leaving the Hilton Hotel in Washington, D.C. Not 10 feet away from him, as he was waving to the crowds, stood a man by the name of John Hinckley Jr. with a .22 caliber handgun. Mr. Hinckley had loaded this gun with exploding bullets and was successfully shot President Reagan through his body armor. You could kind of see his arm upstretched. That was a point of impact. Kind of see him wince there. And this is what his trajectory of the path of the bullet went. Entered his axillary, left axillary, and ricocheted off one of his rib cages and passed the lower lung. Again, this was an exploding bullet. It did fragment up, but you can kind of see here, you see point of entrance and fracture as it come down and began to cause some trauma into that lung. So speaking of trauma in general, the incidence of it is there's about 150,000 deaths every year in the United States alone. And not surprisingly, the most common cause of death is in 40-year-olds, younger than 40-year-olds, males. 40% of all polytrauma or multi-system trauma patients die within 4 hours of the trauma incident, unless events occur to increase the chance of survival. And that's what we're going to kind of cover today in discussing these incidents and how to deal with them and treat them. Thoracic injuries account for about 1/4 of the deaths that occur. So the epidemiology is that immediate traumatic death usually occurs from a rupture of the myocardial wall or the thoracic aorta. And then within 30 minutes, 3 hours, the cause of death is usually tension-pneumocardiac cardiac tamponades, airway obstructions, or uncontrolled thoracic hemorrhage. So this is super important for us in the healthcare professional, particularly in the critical care level, because this is our playtime. We usually get contact with the patients within that 30 minutes, and we treat them for the first hour, depending in flight distances, up to an hour away. So we burn that golden hour, and they are in our care. Early deaths are often preventable if appropriate emergency care is provided, the things that we do. So obviously, we all know the anatomy. There's 2 lungs, there's a heart, and then there's the diaphragm. The other key component of all this is the pleural space in between the lungs and the rib cage. All these have to work in conjunction with each other to create a good ventilatory process. We don't think about this much, but that intact chest wall, that expansion of muscle and diaphragm, expansion of rib cages, all of those factor in not only ventilation and our respiration processes, but it also factors in our blood flow, being able to pull the blood back through the vena cavas into the right atrium for our preload. And all this compensation primarily depends on what reserves those people have. So granted, many of our patients are under 40. They usually have a pretty good reserve, but it doesn't allow us to take it for granted. So our thoracic chest wall is protected primarily through the ribs, through bone structures, even down into the pelvis. We have we have some protection. However, there are some associated organs that we have to consider when we talk about the trauma through the thoracic area. So we have the diaphragm, and yes, it is simply a piece of muscle, but it is paramount in ventilations and also the expansion of the chest wall. Large vessels, so we have the spleen and then the liver, depending on if it's right side or left side. Our main causes of chest trauma and thoracic trauma are blunt trauma, obviously. It's a blunt force directly to the chest. We have a penetrating, or the projectiles that enter the chest through small or large holes. These can also be variable when we talk about calipers or velocities. We have compression injuries, is caught when our muscles or our lungs or anything are caught between two objects. The chest is compressed like an asphyxiation or something like that. And our primary injuries are open pneumothoraxes, and this is primarily toward the thoracic, the upper chest. I have open pneumothorax, simple closed pneumothoraxes, tension pneumothoraces, flail chest, cardiac tamponades, traumatic aortic ruptures, traumatic asphyxia, and diaphragmatic ruptures and cardiac tamponades. And we'll kind of briefly go over all these and the treatments that we can do for them or consider for them. So beginning with our open pneumothoraxes. Open pneumothorax is exactly what it says. There's an opening that is not normal within the chest cavity. It allows air to enter the pleural cavity, and the concern with this is it starts to compress up against that lung. Air travels in through the path of least resistance. So if you've got a large opening, like you see in this picture, the opening there into the pleural space is the path of least resistance is more there than down through the oral cavity. It causes the lung to collapse or partially collapse, depending on the extent of the injury. It can be life-threatening and deteriorate rapidly. We've got increased pressures, increased changes. So here we have a little gun that shoots a hole and creates an open pneumothorax. And as you see, every time we inhale, air goes in and presses out, but path of least resistance will occur. And then as we exhale, the air will escape, come out, air will suck in through here, and pretty soon you've got a pressure building. Continues to inhale and exhale, you can see how that will collapse the lungs completely down, and eventually you're going to have a mediastinal shift. Our signs and symptoms for this is dyspnea. We obviously a sharp pain, subcutaneous emphysema is possible. Decreased lung sounds on the affected side, and then we could get red bubbles on exhalation from the wound, and these are often called your sucking chest wound. Subcutaneous emphysema is basically air that collects in the subcutaneous fat from pressure of air in the pleural cavity. So you can kind of see up here in this x-ray the muscle and then the skin's out here, and you kind of have a Rice Krispie or bubble wrap look where that emphysema starts to occur. You can also have it along the chest wall here. And it will spread. It'll run from the neck to the groin area. So just because we see it in one area, it does not rule out that it's not a thoracic injury. Here we have a sucking chest wound, kind of giving you an idea what that would look like. They don't always produce large amounts of blood, so something to think about. Bleeding can be controlled, it can be fused, and it can be cauterized depending on what the insult was. Okay, let's go back and try that again. So you can see there the chest wound obviously has a sucking. This hole is probably not as large as a trachea. However, with it in close proximity to those lungs without the path, it becomes the path of least resistance, whereas through the oropharynx, it has to travel a long ways down to get to that same area of equal pressure. So simple closed pneumothorax. These usually can happen not only by blunt trauma, but also spontaneous. Extremely tall or skinny people have a tendency to have the parietal tissues separate, and that parietal space just simply separate from the chest wall and cause a pneumo, simple closed pneumo. These pneumos are the ones we don't really get too concerned about. A lot of them will heal themselves. However, in flight operations, if it gets greater than 20%, we have to consider decompressing it. So these are usually self-correcting, but it's something we have to keep an eye on because of Boyle's law. Signs and symptoms of the simple pneumo would be, of course, chest pain. You'll have some dyspnea, tachypnea, hyperventilation signs, decreased breath sounds on the affected sign. And as those simple pneumos get more and more complicated, more air builds up, you could turn that into a tension pneumothorax. And this occurs to the point where there is a collapse of the lung on the affected side. And this results in increased pressure on the mediastinum, on the greater vessels, and on the other lung. This includes the heart. So we can see here, each inhalation will cause more of a collapse, and this tension pneumothorax will continue to grow. So there's nowhere for that air to escape. You'll start to get that midline deviation and a compression of the heart. You'll start to have those effects on the body. So the signs and symptoms of our tension pneumo obviously is shortness of breath or hypoxia. It's going to cause an anxiety or restlessness. They'll have severe dyspnea, absent breath sounds on the affected side. However, be careful of that. Because when enough of the pneumo has occurred, you can get hyperresonant sounds on the affected side, which will sound more of a hollow or a sound coming through a tube. You'll have tachypnea, tachycardia, obviously pallor, cyanosis, accessory muscle use will occur. These patients will present with JVP as the intrathoracic pressure is significantly climbing. You'll also have a narrowing pulse pressures, hypotension, and tracheal deviation. A tracheal deviation is a very late sign. Once you start seeing that, your patient is going to become decreased mental status, and aggressive resuscitation will have to happen for that patient. So we have here our X-ray of our chest wall injury here, our insult. And you can see how this side versus this side, you've got a collapsed lung up in there because of the increased air, the tension pneumo. You are starting to see some midline shift of the trachea. You can see the heart is completely shifted to the right side. The hemothoraxes. Hemothoraxes are quite similar to pneumothoraxes. Various difference is blood. Blood has occurred within that chest wall in that pleural space. Usually occurs laceration of blood vessels in the thorax. And as the blood increases, it puts pressure on the heart and other vessels, not to mention the chest itself can hold 1.5 liters of blood. So the 1.5 liters of blood can obviously cause a patient to go into signs of severe shock. So here we have an insult where we have a hemothorax occurring within this lung, and you can see as time progresses that pressure will continue to go and squeeze that lung until you get your midline deviation and compression of the heart, quite similar to cardiac tamponade. So we wonder, where did this blood come from? And it's primarily that every rib has a major vessel that comes around it, not only vessel but arterial on top of that. So we've got a lot of vascular within that chest wall. And not to mention our lungs is a complex organ of bronchioles, connective tissue in the bronchioles, but it is almost completely surrounded by capillary beds that creates the alveoli. So ruptures of these capillary beds, both the arterial and the vascular side or venous side, can cause the hemos to occur, hemothoraxes to occur. The signs and symptoms of our hemos would be anxiety and restlessness. A lot of these signs you'll see quite similar because of that shortness of breath. Tachypnea, signs of shock. This is something new because we can lose our blood. 1.5 liters of blood within the chest wall can cause a patient to go into second degree, even into third degree shock. Frothy, bloody sputum, diminished breath sounds on the affected side, and there's a really muffled sound. You won't hear hyperresonance with the hemo patients because it'll be more of a muffled sound on that side. You have tachycardia. This is also unique for hemos. You'll have flat neck veins because that blood is draining. It's draining somewhere, and it doesn't have time to build up pressure. So our chest x-ray here and also our CT of hemo, and you can see the complete opacity of the hemo side. A flood chest going out toward away from the lungs, taking a step out toward the rib cage. Flood chest is officially defined as the breaking of two or more ribs in two or more places. This causes a paradoxical movement between your chest wall and the broken area. It'll cause a extremely pain and some difficulty breathing with that. So you can see here we have our rib fractures. Two or more ribs fractured in two or more places would cause that paradoxical movement during respirations. So we're looking for shortness of breath. We're looking for that paradoxical movement. Bruising, swelling, and crepitus can also present at that point on palpation and assessment of our patient. So let's think a little bit about all these different signs of trauma that we've covered. Damage control paradigm is pretty much the standard of multi-system or polytrauma patients that is recognized right now. And the official term, the definition, for damage control paradigm is this: polytrauma patients that are too physiologically deranged to tolerate prolonged definitive repair, where initial interventions are limited to minimally necessary stabilization and hemorrhage control. So that's a big fancy way of saying exactly what J.R. Hess quoted here. It says we have to take planned temporary sacrifice of normal anatomy to preserve vital physiology. And we think about trauma and this trauma control. Bleeding control is paramount. However, we know that oxygen within the blood is also super critical. So we look at this graph here, and you can see at the point of injury or the time of injury, there's going to be and this is at the cellular level, the deeper down we go, the worse we're off in refractory in our O2 deficit, which is harder for the body to recoil from this injury. So what it boils down to is the hypoperfusion creates a accumulated, what they call an oxygen deficit or an oxygen debt. And according to Mr. Hess, this is directly proportionate to the level of shock and duration of the hypoperfusion. So the sooner we can treat this and get this, we have a full recovery possible. But if we go deeper down, we've got a directly proportionate reaction to our oxygen deficit and our recovery. So when we think about our overall trauma care, the cessation of bleeding is the beginning of homeostasis, not hemostasis. So in order to fix and begin the repair process, we have to stop the bleeding, however that needs to be done. Obviously, that is difficult in the field for internal trauma, but our part in minimizing that bleeding can play a key part in their overall care. So some of the things we can do is in this damage control paradigm is we begin our fluid boluses. We can do NS or LR depending on your protocol, but an isotonic solution which will help bring up the care. However, new studies are showing that non-hemostatic and non-oxygenated fluids, which is our isotonic solutions, should generally be minimized. In the past, I know that we've been very vigorous in giving a lot of fluid. However, their recommend now is to maximize 3 to 4 liters within our patient. So when we start thinking of our hemodynamic stability of our patient and the drop in blood pressure and how to manage that, we've got to think farther ahead than immediate. The concerning thing is twofold. Number one is what we see here in this graph. Our vigorous fluid resuscitation is going to cause hemodilution, immunodilution, and capillary permeability is going to get worse. So you're going to have recurrent hypotension, which is going to cause us to push more fluids. You're going to create a cycle that won't stop until that patient is dead. So it is recommended that after our 3 to 4 liters, we consider some other options, consider our blood products, consider other pressors to assist that hypotension. Our goal with our blood products, obviously, is a hemoglobin of 8 to 10 and work our products off that. Interesting enough, there was a study that was done by the Journal of Trauma that showed that 85% of polytrauma patients with hemodynamic stability, when they rolled in the door, were still hypoperfused. So it's something to consider is just because we get within a reasonable or a happy blood pressure doesn't mean our patients are adequately perfused. So make sure we're looking at the other signs and symptoms of our patients. Another thing we need to cover with trauma considerations, not only control our bleeding, but hypothermia. Hypothermia is, interestingly, one of the primary reasons our patients are dying. Hypothermia is brought on by, obviously, the shock or insult of injury. We do a lot of analgesic and anesthetic agents, and this will cause a vasodilation effect, causing the hypothermia. We have our environmental exposure. We often will, as they say in EMS, we strip and flip our patients that we find out in the dark that has rolled their vehicle, and who knows how long they've been out there. So you have a lot of environmental exposures that will start to cause a decrease in that patient's temperature. And finally, we get aggressive with our fluid resuscitation in the multi-system trauma patient. And what it all boils down to is hypothermia equals coagulopathy. So the worse we get, and the lower we get in body temperature, the worse our coagulopathy is going to be. Simply look at fluid resuscitation. Studies have shown that 1 liter of fluid will drop the body temperature 1 degree Celsius. So it's something to consider. So what can we do about it? We can aggressively warm our patients to a normothermia temperature. Normothermia is the key. Some of the studies, some of the Journal of Trauma showed that in our polytrauma patients, uncontrolled hypothermia, which they have defined as less than 35 degrees Celsius or 95 Fahrenheit, there was a marked increase in mortality. So that's something to consider when looking a little farther down here. The NCBI reported in April 2017 that 30% of polytrauma patients arrive at the hospital with temperatures less than 35 degrees Celsius. So we are already putting our patients in a marked increase in mortality. This study shows, back to the Journal of Trauma report, it stated that between 32 degrees Celsius and 34 degrees Celsius, or 89 degrees Fahrenheit to 93 degrees Fahrenheit, coagulopathy increases 10% every decrease in 1 degree Celsius. So you can see that when we bring our patients in, the colder they are, the significant increase by 10% of that coagulopathy. So we're getting farther and farther behind the 8 ball if we don't aggressively warm these patients. The last thing I want to cover is our acute lung injuries with our trauma considerations. These are overall trauma considerations before we get back into our thorough thoracic injuries. So when we have an acute lung injury, it can be from the insult itself or the treatment following, such as the ventilator settings and extensive or long-term care. Also, we have treatment, insult that can happen from transfusion-related injuries. So this is a graph here that kind of covers the three main ones, which is obviously ARDS. We have TRALI and TACO to cover each of those. So your ARDS is your adult respiratory distress. It's basically an inflammatory pulmonary edema, inflammatory response to the lung injury. On your x-ray, you're going to look for that crushed or fine ground glass appearance. And the current studies show that the recommended treatment is to maintain our tidal volume lower than normal, 4 to 8 milliliters per kilogram of the preferred body weight, but to target our plateau pressures less than 30. Some of the studies also support a high PEEP with these patients. So you can work your PEEP up, which will decrease the insult, but still improve the oxygenation. But to remember that as you increase our PEEP, you're going to have an increase in your plateau pressures. So as you increase your PEEP, make sure you focus on your plateau pressures and do whatever you need to do to compensate that, to maintain it less than 30. The next one is the TRALI, which is the transfusion-related acute lung injury. And this occurs after we start giving blood. When we give our blood to our patient, we don't really think of everything else that's going on with the coagulopathy, with the injury that's occurring. And so sadly, the TRALI is the highest transfusion mortality simply because it's not recognized. Our treatment for TRALI would be a supportive lung protective low tidal volume strategy, quite similar to our adult ARDS. So it's something to consider when we deal with our TRALIs. As you can see, a lot of them present the same, but you should be able to see some changes in our lab values, particularly to identify which is which. And finally, we have TACO, or transfusion-associated circulatory overload. The interesting thing about TACO is that just because we assume that we have given too much fluid, that's not always the case. The circulatory overload does not equate to large volumes. It's just more than that patient in that situation could handle. So our primary care for TACO would be supportive, obviously, with our diuretics, and then reduce the transfusion rates that are going on. So when we look across these, try to find out the difference between all three of them, and to recognize that they all are a balance between not only our circulatory system, but also our pulmonary. It helps to make sure we understand what we're looking for and how to treat them. So our vital signs for the TRALI may be febrile hypotension, more common than hypertension. But over here, we're going to have more of a normal thermometer variable with our ARDS. Clinical examination crackles through all. However, remember our S3 jugular vein distension will be seen in our TACO because of that fluid overload. Our fluid balances, and this is where our diagnosis is coming in. Look at our BNPs. will help eliminate some, and then our leukocytes. Excuse me. So as we go into our treatment of chest trauma or thoracic trauma, one of the key things we have to consider is an analgesia. Analgesia is absolutely paramount. If somebody cannot comfortably breathe, then they will not breathe, and you will cause that acid-base imbalance. You will cause additional complications wherein oxygenation and is being affected, when in reality all you have is a ventilation issue. So analgesia is a priority in treating these patients. We also consider our oxygen, obviously. We want to immobilize and splint. We want to make sure we reduce the movement of these patients, particularly on a flailed chest type of injury. You want to splint that so that it will move in concurrent with the surrounding chest wall. We consider our needle decompressions and obviously our chest tubes, depending on if we have hemonumerals. But the key to trauma on thoracic is don't forget those underlying traumas. Don't forget that just because they're having difficulty breathing, we suspect it's a pneumo, then it doesn't mean that there is not additional complications that we need to consider. For example, we saw the x-ray of President Reagan where the bullet had come in. That bullet thankfully lodged into one lung, one lobe, but in reality, those fragments could have gone in every direction, including spinal cord, including the greater vessels, the heart, even the spleen and liver. So don't forget those underlying. This is also super important regarding knife injuries or stabbings, because they have the cone of trauma with those, where you go in with a normal blade, but you've got to think of however deep that blade went, there's a cone, literal cone of where that could have sliced, depending on the angle of that knife or that penetrating injury was. So you've got to remember to think of those underlying injuries. When we do have the open and sucking chest wound, we do our occlusive dressings. Our Asherman chest seals is a commercial device, but something as simply as a piece of plastic or a gauze bandage taped down will do the job to allow that escape of air, escape of blood, but prevent the intake through the path of least resistance. So needle decompressions. We place these in second, third intercostal space, mid-clavicular line. Interestingly enough, this is starting to be reevaluated. Studies have shown that if we will go to the fifth and sixth mid-axillary or axillary line, anterior axillary line, then the success rate is quite a bit higher, partly because of the mass that is on the chest between muscles, breasts, etc., versus on the side. It also has a part in playing how the air flows inside the chest wall. And also, obviously, if it's a hemo, it'll roll toward the posterior if the patient is supine. So what we'll do is we'll cleanse that area using our aseptic technique. Remember, we go over the rib. We have our nerve, artery, and vein line underneath each rib, so we find that rib and work over the top of it. We'll remove the stylet, listen for that rush of air, and then we want to place a flutter valve over the catheter and reassess for improvements. Thing to remember with this is that our catheters must be 14 gauge or larger and at least 3 inches in length. Obviously, this is for an adult. Again, the mid-clavicular or the anterior axillary is the two locations. It is appropriate if you lose that flow to place a second or a third needle next to it in that needle decompression. So when we talked about the flutter valve, there's a couple of different options. Obviously, a commercial device would be the preferred method. However, you could use a finger from a latex glove, or not a latex glove, from a glove. or something like that to create that flutter valve to prevent that path of least resistance, pull additional air in and cause additional insult. With our chest tubes, these are primarily on the axillary, anterior axillary line. This is mid-axillary, which should be axillary. The anterior axillary line behind the pectoralis major will go in the same location. We'll be doing the needle decompressions, which is above the 5th rib, because we want to avoid that diaphragm. If we go too low, we're going to have issues. So we want to go above the 5th rib. There is some area, depending on trauma and attempts, you can go above the 6th rib, but it is recommended to go to the 5th rib to avoid that diaphragm. Once we have a chest tube in place, we're going to connect that tube to a commercial seal, either that or to a Heimlich for flight transportation, and we're going to secure that in place. Make sure we do our checks, our reassessments of our patients, check to see if we've got the outcome we're looking for. Make sure we do chest x-rays to follow up, confirm placement, positioning as soon as possible once we have our chest tubes inserted. All right, so going back to the heart, as if we have insult to the heart, we can have pericardial tamponade, and that is basically when we have blood and fluid leaking into the pericardial sac, which is immediately surrounding the heart. As it fills the sac, it expands until it cannot expand any farther. So as the heart beats and relaxes, the blood will flow in and thus slowly pressure that heart more and more. But the electrical current is still going through the muscles, or the mechanical contractions are still attempting, but it is literally being squeezed to the point where it cannot get volume between the chambers. You can expect your patient's consciousness to begin to drop. Your first signs, of course, is blood pressure starts to drop. Heart rate's going to increase to compensate, but eventually you're going to have a decrease in patient mental status prior to them going into cardiac arrest. So the other signs and symptoms we have is distended neck veins on these patients, because whatever that external pressure is causing the tamponade will also prevent the flow of blood into the right atrium. So you're going to see a distended neck veins with these. With the increased heart rate, as the body tries to compensate, respiratory rates will increase, and obviously our skin colors are going to change dramatically. These are the ones we're going to watch closely for narrowing pulse pressure, hypotension, and death. Death on scene is one of the indications of a possible cardiac tamponade. So our treatment for that is going to be our pericardiocentesis. And again, this is a very aseptic technique. We are going to be placing a large needle into the xiphoid cartilage, or at the angle of the xiphoid cartilage. And we're going to, at the 7th rib, we're going to aim it toward the left shoulder, left clavicle area. Advance the needle at a 45 degree while we're gently aspirating a syringe on that needle. Wait until that we see that blood return. So as we advance the needle in deeper, we'll maintain that aspiration, and we'll also monitor the patient as soon as we start to get an aspiration of blood. The surprising thing about cardiac tamponade is a small amount of blood will make a drastic change in the patient. So even though you might not aspirate a lot of blood out of there, in your opinion, it might be all that's needed for the heart to create enough of a volume, or shift enough of the volume to maintain its beat. So here we have this technique is being used with the Doppler. If you have the FAST 1 system, or not Doppler, but a sonogram. The FAST 1 system does teach this because it is more reliable than watching EKG electrodes and things like that, or doing a blind pericardiocentesis. You can watch that needle advance in to release that blood. Another thoracic injury would be the traumatic aortic ruptures. And for the most part, the heart primarily hangs like a big pendulum in the chest. There is obviously connective tissue that stabilizes the heart, but for the most part, it free hangs. It doesn't physically connect to anything until you get to the ligature of the aorta to the spinal column. And at this point is where the first physical stability of the hanging heart is. So with enough motion, with enough with enough motion, deceleration injuries, things like that, you can have a tear of that ligature and cause your aneurysms, cause your a complete tear, and the patient obviously will decline rapidly. So the chances of survival for these are very slim, depending obviously on the degree of the tear. And a lot of these patients do not make it even to the operating table. These patients are primarily dead on scene, but occasionally when we do transport them, we've got to be very careful. In flight operations, we've got to consider our air turbulence, any hard jostling, anything like that. But if it is small tear, we can get them there. You can see our chest X-ray of the widening of the mediastinum of the aneurysm or free blood within that mediastinum. So our signs and symptoms of burning or tearing sensations in the chest and shoulder blades, sometimes even into the back. We're going to see a rapid drop in blood pressure while the pulse begins increasing rapidly. We could see a decrease or loss of pulse blood pressure on the left side compared to the right side. So it'd be depending on which side of the body it is, which side of the vessels, brachial arteries, etc., that are injured. And we'll also see a rapid loss of consciousness on these patients. We're going to see a severe that got backwards. So it's going into diaphragmatic ruptures. Diaphragmatic rupture is basically a tear within the diaphragm that allows the abdominal cavities to enter the chest cavity. They interestingly happen more on the left side, but that is simply because the liver will protect the right side of the diaphragm. So you'll expect to see some liver injury and some hemorrhage. And these guys it's very, very highly associated with your polytrauma patients. So make sure we have a high index of suspicion for them. The signs and symptoms of this diaphragmatic rupture is a severe dyspnea. You're going to obviously see distended neck veins as there's pressure pushed on the major vessels, bulging bloodshot eyes, a swollen tongue, cyanotic lips. They can present with petechiae. Look for the abdominal pain, shortness of breath, and obviously you're going to get the bowel sounds up into the lungs or into the chest wall, as you can see this rupture of the diaphragmatic. So emergency thoracotomy isn't currently a standard of practice. However, it is being reviewed across the nation or across the world in paramedic and emergency treatment for our patients. I know that in Australia, in England, and some of the areas, they are considering and or practicing this procedure. So the emergency thoracotomy is done when you have a blunt injury with arrest, arriving without a pulse and blood pressure, or if you have a penetrating injury with arrest. the final one is the highly likelihood of isolated or correctable intrathoracic injury. So that's kind of all accumulating into these other ones to make a determination if you're going to do this emergency within hospital or in the field. And our goal for this is to treat these while we can. We do cardiac tamponade, we can relieve that. We have visualization, we can see what we're doing. We have the vascular injuries to thoracic outlets. We can clamp them, we can fix those. Massive air leaks within the lungs. The treatment of that is actually quite surprising. They simply grab lung tissue and spin it in their fingers to pinch off that massive air leak. Endoscopic or radiographic evidence tracheal injuries, they can get in there and treat those. Esophageal injuries. And the other one is if we do a chest tube and you get immediate blood output of greater than 1,500 milliliters or greater than 250 cc's an hour, they do consider going in and doing this more emergency thoracotomy because that is just too much blood to constantly be losing. The thing about emergency thoracotomy, we wonder if it's really worth it, but it does increase the survival rates. So we think, well, it's less than 8% for survival rates. Is it worth doing? Well, if you think back in 2005, the survival rates of cardiac arrest patients was a mere 1%. So we've been very aggressive in changing our medical cardiac arrest patients to the point now in 2017, we're pushing nearly 50% survivability or ROSC throughout the United States. However, trauma has kind of been left behind on some of this. So I expect in the near future, we're going to see some changes, more aggressive trauma as more studies come out to bring up that survivability rate on these patients. So even though we're talking about blunt injury trauma with arrest, arriving without pulses, these patients are clinically dead already. But if we can get even 2, 3, 4% survivability by emergency thoracotomy, then by all means, it seems like something we ought to consider. So in summary, our chest injuries are common and often life-threatening in trauma patients. The key to it is rapid identification and treatment of these patients is paramount to patient survival. And airway management must be aggressive, proper management of these thoracic injuries. There's my references. I appreciate spending the time with you and hope you learned something. Now I'll go do the test.